we'll have the tiniest, most dense and productive little terminology meeting ever. Welcome to the November 16th terminology meeting for Gravity Project. We have a few updates regarding IQR. Hi, Lizzie. And then some reflective conversation at the end, really kind of like looking back at what we've created and just raising elements and decisions that we need to make going forward. Next slide. This is the Gravity Project community meeting. We do always mute. It's not a large number of attendees at this moment, but usually gets to be large. So stay muted unless you are actively talking. And then, of course, I will work the chat to make sure that thoughts are brought in. Next slide. This is the common antitrust practices slide. I am not going to repeat it in full for the sake of all of us, but just note that the first bullet is the most important. The Gravity Project participants have the responsibility to comply fully with federal and state antitrust laws. Next slide. These are amazing sponsors, and we're ever so grateful for them. There's a few new sponsors coming in for 2024 that we're looking forward to. So just grateful for everybody to be part of the sponsors, members, and partners who are part of our work. Next slide. The agenda is just running through announcements and the project schedule and overview. We have a nice little update from some of our co-design work there. And then looking into very, very minimal updates regarding utility and security value sets. Not really any updates regarding interpersonal safety process, but we're just going to be reminding everybody about that. And then there's some things to talk about in terminology build updates and action steps that we'll all reflect on together. Next slide. Next slide. Just a note, again, that we are actively planning for our January Connect-a-thon. It's a virtual Connect-a-thon. The planning is directly leveraging the wisdom of our friends from the technical work stream led by our dear friend Corey Smith from AMA. Monique's on the call, she's part of that team as well. And then we have all of these wonderful people from Lantana helping as well. So that January Connect-a-thon is underway for planning. It's part of the conversations we're having at the 1 o'clock Wednesday tech meeting, and look forward to more information. I do want to give a very brief update just because some of the materials that are already out in the ecosystem on the social care co-design. We talked about the social care co-design process in the past. It was basically like an in-depth centering of a social care voice, understanding that we had long been hearing that our models and activities and use cases might benefit from an in-depth listening session. We hosted that this summer in partnership with Civitas Networks for Health, supported by RWJ. We are actively writing a final report of our findings, which is really the voice of those social care experts on areas of opportunity. It will be disseminated across the Gravity community, and is definitely, the co-design participants themselves will make sure it's representative. But we recently presented at a conference a version of the expanded activities for Gravity directly from the social care partners that we wanted to show you all today. Next slide. If you remember, our kind of base Gravity model has those 4 circles. One circle is for screening, and then there's a circle for diagnosis. Oh, look at the helpful arrows. One circle is for diagnosis, and then there is another circle for intervention. It's broken out here in those 2 blue circles. Again, everything blue is something that we already had. Part of what the social care friends in the ecosystem had long told us is that that model we had didn't represent what they do, right? It didn't represent how they do it. And so they didn't see themselves in those 4 activities. And so part of the products of that co-design session were an analysis of those activities and centering the voice of social care experts in additional opportunities and even sometimes just more granularity within our opportunities so that their world could be represented in our work. Lucy, yes? I think you're muted if you're trying to talk, friend.
Thank you. Sorry. Sarah, when you're finished introducing this, could you discuss a little bit the difference between screening and assessment?
Mhm.
I'm becoming aware that there's a
Yeah.
lot of conversation about whether these are separate.
Yeah.
CMS, for example, doesn't seem to think that these are separate. So maybe we could get into that for 2 minutes. Thank you.
I'm happy to. Yeah. So understand that this has a big draft on it. This is the structure that came out of the social care voice. It has yet to go through the whole gravity adaptation process. So what you see here is the framing of these activities from their perspective, right? With a lot of gravity feedback to try to make it something that gravity could understand, right? But this centering is partly how they defined it and understand that the organization of it might change as it goes through a multi-stakeholder process. But the reason why screening is separated out is because screening is an unnecessary, well, not necessary, it's not a central part of the way social risks are assessed in social care entities. Screening as an activity is a population health initiative or an individually applied initiative, like purpose with the aim of secondary prevention, right? Identifying unmet things. And they felt like the former placement, the primary placement in the model seemed to require it, right? When it is an optional thing, you do not need to screen a patient to know their story. You can just talk to somebody or a client. So for that reason, it was separated. However, it's still a kind of assessment. We have everything in the assessment, again, trying to have this iterative back and forth process. Screening, social risk assessment, holistic assessment, and acuity assessment are all types of assessment. And that helps explain why CMS structures them as together, right? So from a CMS perspective, CMS, if they're measuring things, if you can talk to the patient and hear their story and document the concern, or you can screen and have a screen positive, for either one equals assessment, right? But from a social care perspective, they really wanted to center the fact that screening is not the most common way needs are identified within their expertise. It happens more holistically through assessment and conversation.
I think it's wonderful. Yeah, I think it's wonderful that health and social are getting together over language, functions, everything. So I would just ask whether for anybody on the call are different skill sets or even entire different professions at issue when we talk about screening versus all the assessments that Sarah just listed, the social work and the social risk and the holistic and the acuity, and I think there was one more. Anyway, are we talking about, is there an implication that there have to be different people, differently trained, supervised, monitored, and so forth, doing screening versus assessment?
You'll see a lot of that conversation come out in the final report, so I don't want to steal its thunder completely, but I will state that I'm just going to talk about clinical medicine for a second, like 100% my daily beat. We already in clinical medicine recognize the difference between training and certification, between screening and other kinds of assessment. Any person on my care team can give a screening instrument and score it, right? The social worker I work with, like other people are the ones who are able to assess concerns and put them in a record, right? So the idea that the delivery of a screening instrument Yeah, that is something,
Okay,
and so that's why that's clinical practice, right? And
okay,
certainly within expanded care teams and diverse care teams, it's not just clinical entities that are doing assessing, but one thing that really came out of this work was the desire to recognize social care expertise as an expertise
uh-huh,
that is sometimes born and shared with clinical roles, like clinical social work, for example, right? But it needs to be recognized as an expertise from holistic perspective, especially within the work that Gravity does, right? Because social care experts were very, very clear that they wanted to be recognized as experts because of the critical nature of the work that they do.
I hope in the final report that you will address that, because I could even imagine screening becoming wholly mechanized. You said anyone on your care team can administer a screener. You could put it on the computer before the
It
visit
is, and
or after
one
the
of our
visit or
pilots,
all the time. Yeah.
the state of Oklahoma,
Uh-huh.
has the Accountable Health Communities instrument comes to you as a text when you
Okay.
register.
Yeah. So screening has the potential to be automated, whereas what you've just told me suggests that we would not favor and hope we never see that assessment becomes automated and separated from people talking to each other. Is
Lucy,
that
this goes back to that you asking the must to go in that Accountable Health Communities resource, right? You asked should we in our work on that resource we had that gray line between the questions and the diagnoses,
Mhm.
right? And we had should, like the outcomes of a screener should be
Mhm.
verified in direct conversation with the patient, and you said must be, right? It's that same thing here, right? And we all were like, yes, must. And Sue Bowman from AHEMA, who's on the call, was like, yes, must, right? So
Mhm.
that same principle we see threaded throughout this work. Sorry, I have a
Thank
very
you.
nosy cat.
Thank you
Yes,
for this sidebar.
of course, right? And so just to briefly explain, this is going to be coming out again. You'll see the report, but so these are basically in not every instance is it something like a brand new activity. Sometimes it's taking things apart, like our intervention elements. We've long talked about outcomes. We just haven't had outcomes on our activity list. Outcomes were brought up from an accountability perspective. Our social care experts were very clear that, like, how do we hold ourselves accountable to making sure that the things that we're doing are actually addressing patient needs and solving structural problems. And so anyway, this is a great first initial draft step forward. And then there's a lot more work to do with all of you, and look forward to the report coming out probably in a month, right? Well, not even a month, shorter than that. And then on the 12th of December, on a Tuesday afternoon, there'll be more information around this, that we're actually pulling co-design participants in for a webinar that we'll have with the grand nation at large. So we will make sure to invite you all to that. I'm sorry, my cat is being very, very persistent. All right. Any other questions? I want to note that one last thing before I go, even though it's not completely defined, the health and social care coordination and collaboration activity you see there on the bottom is really important, because what they said, our friends said over and over again, and this is experts in WIC and community action agencies and food banks and housing supports, and faith-based leaders, that they do not want to just share data. They don't want it to be performative. They want to collaborate as partners over time, right? So there's a lot of separate activities that came out of that coordination and collaboration concept. Care planning, longitudinal shared care planning for social needs being one of them. But we left it because it was such a critical thing for them that they wanted to make sure was on the record that this has to happen, right? Don't just send data our way. We have to share care with the people that matter to both of us over time.
And they want to be paid. Shall
And they want to
we,
be paid. That's why we have
shall we
reimbursement
be
advancement.
shall we be upfront about this? They
No,
want
they are very
paid.
upfront about this. Again, this, look forward to
Okay.
seeing this. Yeah, it's very clear. Yes, I promise you there's a lot of focus on equitable reimbursement in the report as well. Okay. And I love that we got to share this draft. And I want to just thank, it was an iterative, very kind of rudimentary work. And then Vanessa connected us with a brilliant member of her team at POCP to make it look like, oh, like looks like gravity. So thank you. Okay, more to come on this. And again, thank you for this early view. Any other questions before we go? Great. Okay, next slide. And then, we have lots of new friends on the call about why I was talking. So next slide. This is the roadmap. Again, well known to you all. We are closing down 2023. We just have a few more meetings and then we'll take our holiday break and come back to you in the new year. We are finalizing a few last education dissemination elements. I am the lame duck when it comes to the process paper that Gravity is working on, which is hopefully you'll all see yourselves in it. Gravity has long wanted to produce a paper that details the processes we go through with all of you to develop the terminologies that are then the reference for so many different programs, because that painstaking process needs to be transparent. So we're working on what we call our process paper. Again, Herculean thanks to Sarah Bahal, Hamali Sejwal, and Monique Van Berghem, because they're leading the charge there, and I sprinkle in elements here and there. But that should be in the ecosystem, if not by the end of 2023, by early 2024. And again, the idea is to have a brief of reference so that anyone can see how careful our work is. And you all are so critical as part of that. So thank you all. Next slide. This is the future. Right now, we do have utility insecurity and transportation insecurity on the roadmap. I'm looking forward to starting the coding for food work in the spring as well, with a lot of possibilities for adding and layering different use cases and domains as we go forward. The operating committee and our members and sponsors are working through ideas on that count. Lucy?
I think I read recently that LOINC and SNOMED have actually started meeting to coordinate what they've been doing independently for decades.
That is true.
Is somebody keeping up with that? Will that influence what we do, or is it just interesting out there?
It doesn't necessarily influence what we do. Well, it all influence. Actually, I'm take it back. It all influences what we do. But the great thing is we have incredibly robust and careful, intentional relationships with both Readiness Reef and SNOMED. We're back to meeting weekly with SNOMED on our digital equity and some outstanding domain build. And we have a really, really close relationship with Readiness Reef. So we are well aware of that collaboration and opportunities to further fill in gaps within Gravity terminologies that might issue from it. But the good thing is we're all very, very good friends.
That's great. Well, I was really glad to read that, because I think they tried that maybe a decade or two ago and it didn't work. So somebody has realized that this really needs to be done, and they're trying again. So hooray.
Hooray. Hooray.
And good luck. Good luck.
Yeah.
Let's hope it works this time.
Yes, I know. So I think we're at this, my theme for the last week is anytime we in the standards world can better organize ourselves, it makes it easier for implementers to implement our work, right? So it's like finding those areas of commonality and overlap and synergy with the work that we're all doing together so that we can present a holistic plan. It's always a good thing.
Definitely.
Simplify. Any other questions? All right, next slide. And we already just questions, so next slide. The next chunks, the IQR readiness, really only have one tiny update. And then we have some pretty interesting things to talk about in the build updates section of the agenda. So I'm going to just run through because there's not a ton new here. And for all of you who've been downloading the spreadsheets, just it's all much the same except for one new thing. Next slide. And just reminder that we are not building any new terminology at this time. We say this, we said this on the slides also, but all we're doing is gathering together what we already have across applicable domains and value sets that's relevant to the domain at hand, and then new build will happen in 2024 for utility and security. And new build will happen in any alternate interpersonal safety domain when those domains are moved onto the timeline. So it's just important to note that new build happens next, collating happens now, even though there is some gap analysis that we're doing just to ready ourselves. Next slide. And then if you, again, there's one new thing. So when the master spreadsheets get uploaded, you'll note that one new thing. We are replying to comments. We have some meetings with some friends in the ecosystem to try to make sure that we're aligned on definitions. But hopefully we are ready to do our consensus vote on the 30th. Again, very, very limited focus for this fall, understanding we wanted to make the best use of time and develop resources to assist implementers ahead of IQR. Next slide. Again, I've said all this before. I'm just going to say the setting for this build is inpatient quality reporting coming into reporting in January. And so us wanting to make sure that we analyzed our resources to be ready. That included work in utility and security, which CMS calls utility difficulties, value sets from existing terms this fall, new build as a domain in the spring, and then some guidance on interpersonal safety. Next slide. Next slide. I just said that. Next slide. Next slide. All right, so just a reminder, again, I say this over and over again, utility and security, new terminology happening spring 2024. And you all are probably well aware of the precedent, but because we're not making any new decisions other than in or out right now, anything aligned with inadequate housing is not in utility and security value sets because it never has been aligned with that. Functioning equipment and plumbing is part of inadequate housing. Anything regarding connectivity to utilities that we found in financial insecurity or material hardship is aligned with utility and security. These are where our terms come in. Interestingly enough, the material hardship question raises some things we need to think about collectively as an as a group that we'll talk about later. Next slide. We will see this slide later. I bring it back. Because this is, yeah, we'll come back to that in a bit, but that's the financial insecurity and material hardship element. And then this is just again a reminder of things that we've already said, is that the biggest gaps, again, I've mentioned we're not doing any new terminology development, but we are doing gap analysis because we're so intimately looking at every single term that's applying. We have a fair number of terms to build regarding representing the insecurity on utilities. Because we do not have very many, we don't have terms to represent that right now. We have lots of not having or unable to obtains, but we don't have the insecurity part of utility and security, and we will look forward to addressing that in the spring. Next slide. These are our amazing SMEs. We had a wonderful meeting with another SME that we hope to confirm as well. Hi, Lucy. Yes.
I just want you to reassure me that water is considered a utility, is it?
I cannot reassure you of anything right now because all I can do is state what we have in our sets right now. One of our questions covers water. The full utility and security domain will be defined and addressed.
Okay. I've been reading a
including-
lot about water scarcity and
Yes.
climate
Yeah.
change and water, and it's going to become much more prominent to people than it has been.
Yeah,
So
so
just
it
want to
is
be sure.
it
Okay,
is part of most base definitions because it is a publicly regulated entity, right? It's like electricity. But I don't want to put myself like a flag in the sand until these lovely subject matter experts help guide us on that matter.
actually, Sarah, in more jurisdictions than you want to think about that I've just read,
Yes.
that whole function is delegated to the private sector. And to say that it's publicly regulated can be misleading in some cases.
Correct.
Okay,
Yes, and I think maybe say classically publicly regulated, which is why
definitely.
it has been grouped in that. And I
How
think
how we all grew up, but it's
yeah,
not going to. Okay, thank you.
but then I think that actually just to highlight, because I'm aware of the literature as well, the the moving away from public utilities creates opportunities for inequities, right? Because
Mhm.
the moment it's not right, but it's something that becomes privatized, it becomes very problematic.
Right.
All right, next slide. Okay, and we're just going to run through no changes in diagnoses and goals. We still have the same ones we've had before. So just going to click through, nothing new there. And I hope it's okay to move through because these have been on the master list for a while. There's nothing new. I want to get to what the things that are new. Programs, professions, and roles. Nothing new here. Everything we had before. Screening instruments, there is something new. We found a question. There is both a short and long version of our AFP social needs screening tool. We had the short, we did not have the long. So out of our due diligence, we are adding that instrument to our list. Not a huge shift, but still one that needs to be noted. And next slide. You can
Sarah, what is the difference between short and long here? Are we talking 5 minutes versus 20 minutes or pages, or what is that?
It is like a 1.5 page versus a 1-pager.
Thank you.
And there are interestingly different questions specifically in housing across the two instruments.
Thank you.
Yeah, and because of that, so the instruments are different enough that one of the instruments does not cover either housing instability or homelessness. I'm trying to remember, and the other one does, right? So there's enough differences that the two instruments are not covering all of the same domains.
This is a problem for them. They should have one screening tool, right?
Yeah,
In the
they
best
do.
of all
They do
possible
mostly.
worlds.
Yeah, they do usually use the long one.
Okay.
Yeah, and it's the one that's easiest to implement and most common.
Thank you.
Yeah. And it is largely built off of the Accountable Health Communities Health Related Social Needs Instrument. So there's a lot of commonality across, like we've said in other instances, the panel name is different, but the questions are actually very similar. And you can see that when you look at the questions themselves. So when we finish, when we have our complete guidance for utility and security, and you look down the questions on the beautiful spreadsheets that the terminology team makes on the terminology value set page, you can see the question similarity across the instruments. The base or origin question for almost all of the utility questions is a Children's Health Watch authored question. Notably, Children's Health Watch is the same group that provided SMEs for utility and security, right? But also authored the Housing Instability Vital Sign and the Hunger Vital Sign. They're very, they're leaders in the ecosystem and brief, highly validated questions for social domains. Next slide. So not all screening instruments are in the public domain, but all the Children's Health Watch ones are. There's information on licensing with each of I think the AFP one, you just need permissions, but no fee. Some of the instruments require fees. It depends on the instrument. but the AHC one does not, and the Children's Health ones do not. To the best of my ability, haven't looked at them recently. Just making sure I don't get myself in legal trouble. All right, interpersonal safety process, no updates here, so we're just going to move through. Just a reminder that when Gravity addressed interpersonal safety, guided by our subject matter experts, they divided interpersonal safety into measurable distinct subdomains because each of the different subdomains have unique dimensions, instruments, and interventions. So there was no evidence-based way they felt to lump interpersonal safety. You can actually see this in guidance regarding screening. Like if you look at United States Preventive Services Task Force recommendations for screening for interpersonal safety, the only subdomain that has any recommendations that's category B for screening is intimate partner violence, which just kind of elevates the fact that each of those different subdomains have to be considered independently. So for the purpose of Gravity's work, we initially divided interpersonal safety into elder abuse and intimate partner violence. That does not cover all of the different subdomains. We talked about this at the last call. We'll talk a little bit more about it in a few minutes. Next slide. Just want to note that the Health Equity Accreditation Plus, the NCQA program, also has interpersonal safety. And we're really grateful to be coordinating with our friends at NCQA to ensure alignment across our recommendations for IQR and Health Equity Plus and everything Gravity does. Gravity and NCQA are very, very close. So I'm looking forward to giving guidance there as well. Next slide. This is just a note on the instruments. The interesting thing to note on these, if you look at the patient quality measure reporting screening for social drivers of health measure, which is the one that comes into reporting in January, there's some general recommendations for instruments, and then they point you to allow you to use whatever instrument you want. So there's no specific guidance on what instruments to use to address the interpersonal safety element. NCQA offers a few instruments of guidance and then points to the Siren table, the Siren 2019 table of instruments. So that's just the general guidance on the instruments you can use, understanding that both of them are non-prescriptive and suggestive. Next slide. Just in general, where we have landed on the best Gravity can do within our scope is the following text, and then the next, there's that flow sheet we worked on last time. So according to the evidence, and this is evidence across all interpersonal safety subtypes, is any interpersonal safety screening needs to be prefaced with the CUES model. We'll talk about that in a second. And then whenever you screen for general interpersonal safety, you should follow up with questions that direct teams to distinct interpersonal safety subtypes. This can happen either through interview or through application of diagnostic criteria for those separate different subtypes. Where Gravity inserts itself in that general recommendation is once you have a general interpersonal safety positive, you have to determine what type of safety risk the person's at. Where Gravity steps in is we do give guidance and standards for elder abuse and intimate partner violence. And so we can direct you to those value sets. And then we have a little or need for further assessment. Just a note that in meeting our members and our implementers in this recommendation, it highlighted that there are areas of interpersonal safety that we've long known we needed to address, that we have yet to address, that are in our sandbox. And these are child abuse and abuse of non-elder vulnerable adults. These are kind of the last two highly specific, distinct, sensitive types of interpersonal safety that Gravity needs to address to complete that domain, the meta domain. Next slide. This is the CUES model again. Really grateful that Reg and Streif is working on releasing that. So we'll be able to have standards for representing CUES, which is really just universal guidance on safety, universal education. Every single person gets education regardless of whether they're yes or no, and even before they've even been screened, and then support. Next slide. And this is how that flow sheet looks. Again, if you get your interpersonal safety screen positive, really the best way to get to the granularity of the different types of abuse in the adult population, because that's where we are for IQR, is to ask questions on the perpetrator. And there's distinct pathways based on the perpetrator that take you to our two IPS subtypes. Those further guidance to be determined is if you had children, this would not work. And in the presence of a non-60 to 65-year-old adult who meets the trusted caregiver criteria, that's where that abuse of the non-elder vulnerable adult would come in, because the same reporting requirements reporting to adult protective services apply. And we held that domain when we addressed elder abuse in the past, because we wanted to get different subject matter experts to help us, because at the time our subject matter experts were largely elder abuse subject matter experts, and they wanted to just make sure they had other friends to help them. Any questions on this little, again, it's just an assist, like how an implementer would get to gravity standards from the current RAC. And then also assisted us in making sure we had child abuse and abuse of non-elder vulnerable adults on the roadmap.
Sarah, I don't know why I'm the only one ever asking questions today, but I just want to be sure that I understand, going back to that slide called population health, all of this, what you're calling assessment, goes in that bubble called screening. Is that true?
Well, here, let's walk you through there here. So let's go back to the slide, and that's a really good question. Oh, sorry. Let's not go backwards. Let's go to the algorithm. I'm sorry, Hamali. I'm gonna, if we go to the algorithm, I'll apply what I thought of you. I thought of that when we made this, right? I promise. I always have my friends of assessment in mind. So this is why the screening word is in that purple box, because that's what the regulation requires, is that you screen, right? And everything following after is assessment, right? Because we did not recommend that you re-screen a patient with a different instrument after a general 8-question interpersonal safety screener, right? That would be laborious and not conducive to patient-centeredness, right?
Right.
So that's why the word assessment is here, and questions, talking to people. Mm-hmm. Because if you simply talk to the person and ask them questions about who the perpetrator was, and then talk to the person about the kind of harm they had, again, not reapplying a screening instrument, then you can start, it's like the screening instrument part's been done. And then if it's positive, you get to drop the diagnoses, apply the patient-centered goals, and have all the interventions, everything that happens after screening for gravity for those two domains would apply. Does it make sense?
Yeah. Somebody's trying to reach me. Just sorry.
Oh, she got a phone call probably. But for others on the call, does that make sense? That we're not recommending additional screening instruments. We're recommending conversation.
I certainly support that. If I'm the person trusting enough to even get into this subject, correct, the idea of referring me onward and going through the whole thing again is awful. And correct. I bet, people wouldn't show up, or they wouldn't do it, and so you've lost them. Correct. So screening creates a ping. Screening is always an opportunity. The same thing happens in other areas. Like if I have in depression, if I have a PHQ-2 positive, which is a depression screener, right? I talk to the patient. I apply diagnostic criteria. I analyze to see if we're, working with a major depression diagnosis, and then I assess them, right? Or I refer them to the social worker in my team who can help, right? Mm-hmm. Yeah. Because like a ping positive PHQ, your process can be anything. Any qualified person in the care team can do
this, right? Licensed social worker or whatever, but that's that was the recommendation we gave.
Thank you.
Any other thoughts there?
Hey,
Great.
Sarah, I have a question.
Hi, Amy.
So what results in a diagnosis? The assessment does, but with a screening, does that result in an actual diagnosis?
No, screening, and
Okay.
again, this is really something we're really trying to clarify. Screening should create an opportunity for assessment.
Okay. Okay.
Right?
I just want to.
Yeah,
Yep.
you're entirely correct, right? So and that's again, like the theme, why there's that gray line between, the questions on the AHC instrument and the diagnosis. And this is very consistent with all other recommendations for screening in the ecosystem. Like there's big warnings on the PHQ-9, like do not apply, like all of these things have to be considered before you say they have major depression, right? Talk to your people. So those same principles apply here. Monique?
Yeah, I'll just add here because our IG can create subtle confusion on this. So our implementation guide does sort of advocate that some observations using a structure map, which is a fire structure, can be converted into conditions, which many people associate as being diagnoses. However, there is a caveat with that should only be converted into an unconfirmed condition that is flagged as a health concern. So in other words, that doesn't become a condition or a problem list item unless a provider further assesses it. So there is some, in our implementation guide, some conversion of screening observation responses over to conditions, but that's with the caveat that they're unconfirmed and they're just called health concerns.
The way that I conceptualize that, Amy, and just to build off it as a clinician, like how that would happen, is just thinking again about what happens with depression screening, right?
Mhm.
Like I get a suggested major depression, please confirm, right?
Okay.
And
Yeah.
that is essentially what's happening in our IG. Suggested food insecurity, please talk to the patient and confirm, right? And that is something that we enable because the instruments, the best instruments, right, are really able to do this well, right? And in the name of social needs, it's not as subjective, right? If a person does not have enough money for food, it's fairly straightforward, right? But we still built into our IG that pause because that principle has been part of Gravity from our first moment, right? That from a patient-centered perspective, you have to talk to people to confirm diagnoses. Sound good?
All right. Thanks.
Yeah. That was making more of an answer
But
than you wanted.
that isn't what Monique said. I understood Monique to say that a provider had to move from this is a health concern to this is actually a diagnosis with a code. Did I misunderstand that?
But that happens through conversation, that process happens through talking to the person. Ideally.
Correct. That's so, it's just that in the workflow that may now get flagged as a health concern that's unconfirmed for the provider. And then that's a signal to the provider, just like an abnormal lab test to look for have a further interaction with the patient. That's how I would. Yeah.
Yeah.
Thank you. I hope everybody understands it that way.
Yeah, we've tried to, articulate that as well as we can. The fact that it's unconfirmed and that it's categorized in fire as a health concern, not a problem list item or a diagnosis. But this is all a learning process. So feedback may tell us otherwise.
Because when you first spoke, Monique, I imagined that the notes in the electronic record, maybe they had to go to the psychiatrist on call or the psychiatrist outsourced or the psychiatrist who comes in next week, or that's not what you're saying.
And Sarah, you can correct me, but what I'm saying is in general, these screening instruments are provided by some provider or somebody who's responsible for the output of that instrument. And that once those results are available from that screening, they are provided to that provider, who then takes the necessary steps to whatever needs to happen. But first, to me, it's first that they then confirm with the individual the findings or the concerns on that screening tool, and then they take whatever steps are next. I don't think this necessarily gets outsourced in the middle of the night, et cetera. I think it's more, this is part of a patient interaction with the provider.
I think there's a real, I see Sue commenting on this. I think there's because of how many different opportunities are kind of like coalescing. I think about, this, algorithm. I think about the Accountable Health Communities resource we produced. I think about the findings from the co-design report, right? I think about, us working with one of our pilots, track 1, New York, on how to translate the screening questions they're getting from the impending waiver, right? I think this moment in time is a great one to disseminate, get some kind of brief out there to say everywhere across all of our resources in all of these different ways, we're saying the same thing, right? So I just want to note that that's something that it's an unwavering principle. And we can speak to it from all of these different avenues now. The resource, again, the algorithm, the co-design, and the IG with clarity, just to show that we're holding steady on that, I think. And maybe our friends at AHIMA can help. Just a nod that we have friends who, who can help us make that message. Sound good? I'm gonna give it a thumbs up. I'm gonna give my own thought a thumbs up. Okay. Because again, there's just so many things that say the same thing right now. So it's a really great moment to tie them all together. Again, simplifying. All right. Yes, and Sue, I know that too. And I think it's really important to state that from, in all of these ways, again, Gravity as a community has built in a pause, right? By design in the IG, right? By design in our resources, right? By, as confirmed by our social care friends, right? We can solidly state this. I think that message would be really important to state, and it can be a quick one. Yeah. Yes. Thank you so much for the question, Amy. That was really helpful. All right, next slide. All right, now we have some updates. Next slide. This is a fun one. Next slide. Lo and behold, our friends on ICD, our ICD friend and experts helped us understand that a long sought for ICD-10-CM term to represent veteran status was released in the October 2023 release. So in 2021, we worked on yes, true, Sue. In 2021, we worked on a submission for a unique ICD term for veteran status with the VA. It was kind of passed along, kicked down the road for a few years. And then is now in the ecosystem as part of the 2023 release. So personal history of military service is now in there. And again, extensive thanks to our friends at the VA who wanted this term and helped work with us for this term when we addressed veteran status in 2021. That's another star on our social risk ICD-10 diagnoses built. Next slide. We then want to talk to you just about, we had a conversation last time regarding some subtle changes to ICD-10-CM submissions for digital access and digital literacy. We wanted to show you what that's going to look like. We're about to submit that. I have some writing to do to get ready for that. But just generally, because of a need to align with utility and security and thinking about possibly consolidating communications and communications access. We're holding right now on ICD submissions for digital access, but going forward with all SNOMED CT as planned. So no new ICD for digital access either on the community level. And then next slide. And then at the person level, still again submitting SNOMED CT, because again, these will map to whatever existing ICD-10 term we realize we want in the future. Next slide. And then this is again the last personal level term for digital access. Next slide. However, we are going forward based on precedent. We submitted a problems related to health literacy term when we addressed health literacy last year. So again, built off that precedent, recognizing at least the unique nature of digital literacy and its critical role in, especially in modern healthcare. We are going forward with the submission and asking for code Z55.7 for problems related to digital literacy. This will be a parent concept encompassing all of the more granular SNOMED CT terms we are asking for, including general digital literacy concerns and basic digital literacy concerns. And then on the next slide, all of the other subtypes we have. Thank you, Monique, for the verbiage from the IG. Great. And so then that general ZP5.7 problems related to digital literacy would also map to those other more use case specific digital literacy barriers that we discussed in our build. Fantastic. Next slide. And just one thing, Lucy, like I just want to note that what you're saying there, like even in reimbursement approaches, and someone can correct me if I'm wrong, I think about the emerging, there's 2 new HCPCS codes coming out for social risks in calendar year 2024, one for social risk screening and one for community health integration. These are specifically social determinants of health code. So reimbursement has always been conceptualized as separating screening from deeper conversation. And that's reinforced in these 2 terms. Like the community health integration term, the great thing about that is it's possibly in partnership with a billing provider. We can talk more about this next time. But community health workers can start to take some of that role. There's a lot and see it in the community health integration term, the navigation coordination. But assessment is very clearly defined, and what components of assessment matter in that CHI term. So even in reimbursement, the reimbursement models have always centered that truth, whether it be from evaluation of management codes. This is how I bill, because as a clinician, because I can assess, right? So just noting that gets reinforced in payer policies and all kinds of other policies through SEMS. I hope that I didn't go rogue there, but just note that there's multiple drivers to try to help us get this right. And I think we're positioning ourselves well to try to make sure that the gravity perspective is.
That's good, because not all providers meet your bar for integrity.
You're very sweet. But yeah, this is
well. Let's be realistic, Sarah.
No, you're right.
We wouldn't have the kind of controversy we have about the cost of healthcare if we all thought that all providers met the bar that you have radiated for a long time.
Heard. Lucy, you're always a very good patient advocate, and we appreciate you deeply. Now for the last section of our call. Here I thought it was going to go on forever. We are going to end a little bit later than 5, but not 5:30. This is a sticky wicket, and so I'm looking forward to having you all help us here. This is the kind of conversation we can only have when we've been really successful. And I will tell you why, right? So we're going to ground ourselves again in the definitions for financial insecurity and material hardship. Financial insecurity is that state of being where a person has difficulty fully meeting current and or ongoing financial obligations and they don't feel secure. Material hardship is the lack, like I do not have a socially perceived basic necessity, right? So these kind of overlap in the middle, but it's like everything from worry, difficulty paying to not having, right? And these are domains we addressed in 2021. Next slide. All right, so the concepts within material hardship and financial insecurity value sets issue from our 2021 bill. At the time, based on evidence and definitions, anything about general worry about not having enough money was placed in financial insecurity. The cardia screen's a great example about that, like of that. Do you worry about not having enough money for food, housing, right? If there was a question or a concern that was clearly, I don't have it, right? Then that becomes material hardship. Worrying about not having enough medication at the time was put in financial insecurity. Not having it was put in material hardship. Worrying about paying for utilities was put in, well, it would have been put in financial insecurity, but not having utilities because they've been turned off was put in material hardship. That was awkward even at the time. And it was done because we were early in our processes, and these are really important general concepts. But in some sense, every single socioeconomic concern we have could be a child of either two of those concepts, right? Everything can either be food insecurity as part financial insecurity and part material hardship. Housing insecurity is part financial insecurity and part material hardship. So you can see it gets a little complicated when we think about curation and maintenance of sets. So then material hardship sets had the spectrum of instruments, diagnoses, and interventions for domains we had not addressed in 2021 at the time, right? We addressed food, housing, transportation, all kinds of other things. Everything else was just thrown in the material hardship bucket. Next slide. We've recognized the material hardship problem child for a very long time. The problem is, right, once we build a more specified domain, what do we do with the codes that are in material hardship, right? Like medical cost burden and utility insecurity are great examples. If you look in the diagnoses that we have and the conditions that we have in the material hardship value set right now, there are only 3 concepts that we have not addressed independently because we just keep on going. Gravity thought it was going to be around for a year. It's now 4.5 years in, and we are healthy and have more domains on our list and have more things that we have to define. And we're just, there's a lot of other things that we have to do, right? So since 2021, we have pulled out medical cost burden and utility insecurity and digital access and digital, so these are all things. And so everything in bold is something that's in material hardship, but could be moved to be only someplace else. So if we moved them, eventually the material hardship domain would only contain concepts that were not represented in other domains. It would be like an unspecified bucket. So at present, if we applied the standard, it would have clothing and childcare and adult dependent care. 3 things, right? Next slide. We are not going to come up with an answer for this question right now. And just like the conversations on digital access holding through utility insecurity through spring 2024, we want to do the same with this problem, right? We really want to make sure we do an in-depth analysis of material hardship domain concepts to identify overlaps. And we want to consider whether we adjust material hardship value sets to only include codes not represented in other domains. Because ideally, we want to point people to this, because ideally we want to point people to the specific domains when we can, right? Or material hardship would have to contain every single possible intervention known to man, because if you have the concepts and the value sets, you need all the other things that go along with it, right? Does it make sense, this problem? It is, material hardship is a rather vague and general term. Sue Bowman, correct. It was created by necessity. Yes, but it's been problematic since its creation. Yes, I'm glad it was riveting, Amy. Thanks for coming. Is the problem clear, right? Like, how do you solve a problem like material hardship? I won't start singing from Sound of Music, but is it clear?
I think this is going to be a really interesting discussion.
It is.
Because ultimately, or maybe underlying everything, when a patient presents with problems, the system wants to help them.
Mhm.
There may be realms or levels or types of material hardship that the system can't help with.
Mhm.
And we should talk about that and whether we want to maintain that for research, if nothing else, because it would be important in general discourse about social welfare to know that there's something called material hardship out there, and so many million people are classified that way.
Mhm.
So how are we going to think about it? So I think this is going to be an interesting discussion, and thank you for making time for it.
Yes, it will be an interesting discussion. And again, I think also we have to know that like not every domain that's possible within material hardship will rise to the requirements of encoding specifically, right?
Yeah.
So yes, I know it's going to be interesting, but as long as you were all aware, now you're all with us, because this has been an internal conversation within Gravity, internal terminology, and it's like we all have a little sigh. At least I sigh outwardly whenever I think about material hardship. I'm like, oh, it's problematic. I'm sorry, my cat is like right next to me. But yeah, we'll talk more about it as we go through 2024. Holding space for it. Okay, next slide. And all right, that's a meeting finishing not too far off of our 5 o'clock 1 hour goals. Again, there's only one new concept, and that's one new question in utility and security, and get ready to not, right? Very correct. So it's not used in ICD 11, but it is this, yeah. Yep. It might just be able to be represented in like a non-specified Z59. You know what I mean? Like, I don't know if we need it, if we can address it otherwhere. Is Sarah breaking up? World Propaganda is right. Okay. I'll let you all go, but review the utility and security master list. Get ready to come back to vote on November 30th after the holiday. Join us in the Wednesday meetings, 1 to 2. It's where a lot of the Connect-a-thon planning is happening. We do want to make sure we have friends to test. We have our final for this cycle Pet Pilots workstream meeting at the end of on the 30th as well. We have one of those back-to-back long days. Have a lovely Thanksgiving. For the first time in years, my whole family is coming to my house. They always used to, and now everybody's coming. Everybody. So many pies. And thank you all. Any final questions before we go? Thank you all for this lovely, sweet little conversation. It was a great little meeting, and we'll see you in 2 weeks.
Thank you, Sarah.
Thank you, Sarah.
Thank you.